Okay, great. Thanks, Ian. Okay, we're going to get started. Good afternoon, everyone. I'm Tom Wolf, and I'm a member of the HASP Science, Medicine, and Technology Committee, and it's my pleasure to introduce Dr. Mukkamala. Dr. Bobby Mukkamala earned his MD from the University of Michigan, and he's a board-certified otolaryngologist, head and neck surgeon who's in solo practice in Flint. Dr. Mukkamala was elected to the Board of Trustees of the American Medical Association in 2017, and he was the board chair for the AMA for a year ending last month. And he's also the immediate past board chair. That's his official title. Dr. Mukkamala has also served as a member of the Michigan State Medical Society Board of Directors since 2011 and as board chair for 2 years. Dr. Mukkamala will discuss his observations regarding the evolution of technology in various aspects of healthcare. He will share his thoughts concerning how technology can be extremely useful in improving healthcare and how it also can be a barrier to the improvement of healthcare. In addition, he will discuss what can be done to ensure that technology development is truly helpful to patients and physicians. And just as a personal note, I work closely during my career with many physicians in my roles at the American Medical Association, the Michigan State Medical Society, and with a private consulting company. One of the physicians with whom I work closely is Dr. Mukkamala, who is one of the most respected physician leaders, not only in his hometown of Flint, but in Michigan, in the state of Michigan, and in the United States. So I'm very grateful that Dr. Mukkamala has chosen to take time from his very busy schedule to make a presentation to HASP today. So Dr. Mukkamala, welcome. The floor is yours.
Thank you very much, Tom, for that very kind introduction. I thought you were going to say when you said you were talking about me, I thought you were going to mention my dad when you were talking about.
No, but I've known your father for longer than I've known you, for probably 30 years. I've known you for about 15, I'd say. Yep. And yeah, your dad and I go way back.
Yep. That's I thought you were going to mention him, but yes, it's been nice to follow in his footsteps and pave a different path as well. So thank you again for those kind words. And thank you for the opportunity to join you today. I'm going to talk, as Tom said, about technology and healthcare, and just in general, sort of how the American Medical Association views the role of technology in healthcare, its future, and a physician's role in creating that technology. It seems that every day there's new technological advancements that promise to revolutionize healthcare, and the question is, do they work as promised? Are they easily incorporated by medical practices? Do they improve health outcomes for patients? At the end of the day, that's what we want. Not a theoretical benefit, but an actual benefit. And are patients able to have access to these advances? And those are kind of critical questions as we assess the evolution of technology within healthcare. And how can we be certain that technological innovations of today and tomorrow are designed and used properly and distributed fairly? So in my talk, I'm going to look at some of these emerging trends in healthcare and highlight how the AMA is supporting this innovation in healthcare and why it's important for physicians to have a voice in the design and creation of these new digital tools. I'll also mention that, at any time you have any questions, I'd rather this not be a monologue as much as a dialogue. So any questions that you have, feel free to type them into chat. We've got that monitored, but would love to, because we're going to be talking about a very diverse sort of subject matter between now and the end of this. And instead of waiting till the end to get back to something that I said half an hour ago, feel free to type it in the chat, and we'll answer the questions as they come up. So as far as, who is the AMA, let me just take a moment to introduce myself and the organization I represent, the American Medical Association. So again, I'm an otolaryngologist here in Flint, Michigan. Flint is the town that welcomed my parents, who moved here at the age of 25 as immigrants from India. My mom is a pediatrician. She finished her residency at Hurley Hospital here in Flint, and my dad is a radiologist who also did his residency at Hurley. So at the age of 25, they moved to Flint, didn't really know anybody. And 9 months later, I was born. And now 51 years later, here I am, still in Flint. I attended the University of Michigan for 7 years, which is where I met my wife, Nita, whose desk is right behind me. It's not usually that clean. I just took everything that usually clutters it, and it's all right here behind my head, behind us there. But Nita and I share an office here in Flint. She's an otolaryngologist. I'm sorry, I'm an otolaryngologist. She's an obstetrician gynecologist, a little mom and pop operation that our patients affectionately refer to as the place to go for earwax and pap smears. It's not what's on our business cards, but this is what we're known as in town. We both did our residencies in Chicago and then moved back here again 22 years ago. I dragged her here a little bit kicking and screaming. Nita really loves Chicago, but she accuses me of impregnating her with twins, and therefore wanting to be close to in-laws and parents to help to raise them. So they were born in my last month of residency, and of course now are 22 years old and just graduated from college, as you might have heard Tom and I talking about earlier. And as far as the American Medical Association, I serve on the board of the AMA, as you heard. So this is my 6th year on the board, and serve as immediate past chair. And about the AMA, so it's a Chicago-based institution that's 175 years old. And it's the largest and the most influential physicians organization in the United States. Back in 1847, we adopted our Code of Medical Ethics at our founding meeting back then, and articulating the values that still guide medical practice today. So, very much important and critical in the evolution of healthcare in this country. So the AMA House of Delegates, which is our policy making body, sort of the Congress of Medicine, if you will, represents 190 state and specialty organizations across the United States. So every state is represented. Pretty much every specialty of any significance is represented in that policy-making body. And so this group, the House of Delegates, establishes the policy that guide the practice of medicine in a very democratic process, and that anybody could come up with an idea. I remember one of my first ideas for a resolution when I was an alternate delegate, so just getting started at the AMA in the early 2000s. I was quite irritated that sitting in my office, pharmaceutical representatives would come into my office and they would pitch me on whatever was the product that the drug product that they were selling. And they knew exactly how many prescriptions I had written and for what drug, whether it was their competitor, whether it was their drug. And that bothered me. I thought, this is not something, I just don't like the constant interruption in my office. Anyone that's been to a doctor's office, how irritating it is when, as a patient, you're trying to talk to the doctor, and meanwhile, they're talking about, the pharmaceutical rep conversation happening in parallel. And so I wrote a resolution that basically said that our prescribing information should not be available to the pharmaceutical industry, right? That's just something that's between a patient and me. And the House of Delegates liked it. It established that as policy. And fast forward 6 months, and no longer was that information available. And so this is sort of from idea to policy, what happens within the House of Delegates. So it influences policy decisions about medical practice and patient safety at state and federal levels. And the House of Delegates has led or helped advance major public health initiatives around everything from smoking to vaccinations to opioids to automobile safety, and now especially during this COVID era around COVID-19. So the mission of the American Medical Association is to promote the art and science of medicine and the betterment of public health. So very simple, acknowledging that medicine is both art and science, and that our overall goal is to improve public health, which is exactly what we strive to do every day. The strategic priorities of the American Medical Association. So we represent physicians with a unified voice, a united voice, to government and other stakeholders in medicine. Obviously, medicine being what it is more than just the physicians and patients that are involved. There's many other entities, those that cover it, those that supply it. So many other stakeholders. And so again, representing physicians with that unified voice. And we're delivering on our mission by working to remove the obstacles that interfere with patient care. Things like prior authorization, right? Something that just I see as an impediment. I just see the stress that it causes in my office staff when I and the patient agree that something needs to be done, but there's this permission seeking that has to be done. That's an obstacle that we try to improve those things because they interfere with patient care, leading the charge to prevent chronic disease and confront public health crises, whether that's, diabetes, whether that's hypertension, whether that's COVID, the burden that puts on our system and our population is something that the AMA seeks to improve with this work, our public health work. And then also driving the future of medicine through innovation and improved physician training and education. So everything from undergraduate education to graduate medical education to continuing education after we've gotten our degree in practicing medicine. And then also improving innovation within that space to make our jobs easier and our outcomes better. So, the topic of this talk, technology in healthcare, its promises and pitfalls. So technological advances will continue to change the way physicians deliver care. The history of medicine has always been a history of innovation and change, right? I think back to, we literally used to use leeches on people to bleed them of their bad humors. We used to, even in my lifetime, when I was a resident at Loyola University in Chicago, when somebody had an ulcer, we thought that the right thing to do was to cut out the ulcer, right? So we did partial gastrectomies all the time in general surgery to remove the ulcer by cutting it out. Now we know, and there's a Nobel Prize that was awarded, that those ulcers are oftentimes, almost always, due to the presence of a bacteria, H. pylori. And so now we treat with antacids and we kill that bacteria and the ulcer goes away, right? So this is the innovation and change that's throughout the history of medicine that continues. So think of the thermometer, the stethoscope, the microscope, the X-ray. These were all landmark innovations of their time and huge improvements over what existed before. And so the revolution continues into digital health, right? And so from big data and electronic health records to wearable devices and telehealth, right? My smartwatch that tells me, I was a little irritated yesterday. There's a 10-mile race in town called the Crim Race. And so I run that between May and August. We're in a training group and we had run 6 of our 7 miles. And then my watch finally detected that I was doing a workout, right? 6 miles of wasted running before my watch finally caught on that, hey, this guy's running, let's keep track of his calories, right? So just another example of technology that's intended for good purposes, but doesn't always work out that way. So again, the wearable devices, and then telehealth, something that we've seen, I'll talk about more in just a little bit, and then artificial intelligence, or as we in the American Medical Association prefer to say, augmented intelligence, right? We're not replacing our brains, we're augmenting our brains with AI, augmented intelligence. So these advances can dramatically improve patient care, but at the same time, we have to take care to ensure that the technology is thoughtful, that in its design, so that it works for both patients and physicians, right? So if somebody relies on this, that can be so off as to miss 6 of my 7 miles, then to rely on it to measure pulse and pulse oxygen level or blood oxygen level is something that needs to sort of pass a certain threshold of quality. And that may sound simple, but it's proven to be difficult in practice. So as far as the lessons of electronic health records, so you're likely familiar with EHRs, or the medical record called EHRs, or EMRs, electronic health record, electronic medical record. I was never big on separating those two. Some people will say there's a nuanced conversation there about what's constitute an EHR versus an EMR, but it's that, it's the iPad screen or the laptop screen that your doctor is always tapping away on when he or she is supposed to be listening to you. And so, my standard posture in my exam room is this, right? Because I'm typing as I'm looking to the patient. And luckily my typing skills are decent enough that I can do that, but there's a lot of spell check and edits that happen because of that. But the goal is, again, patients like it when you're looking at them and talking to them. And I like that also, but this is sort of, what the consequence of EHRs. It certainly has made medicine more efficient. For example, your physician can now easily order a new prescription and have it delivered to your pharmacy immediately with a tap on the screen, instead of having to write it out longhand, give it to you to bring to the pharmacy and have you wait there for half an hour. Now those things can be ready when you get there. So there's clearly great benefits associated with it. But if EHRs had been designed to be efficient and evidence-based and interoperable from the start, they could have revolutionized medicine, right? But instead, for physicians, they've been, in many cases, a huge headache and haven't lived up to their promise or potential. And here's why. So years ago, when the US Congress and federal regulators began to incentivize the use of electronic health records, the vendors became focused on meeting these regulatory requirements rather than on meeting the needs of their customers, the physicians, right? The end users, people like Nita and I. So other than meeting federal reporting regulations, EHR developers had very little incentive to innovate, right? So meet the requirement of the federal regulations, but not anything past that. And so the much needed competition that oftentimes sort of drives progress and drives innovation was all but stripped away by these requirements, because physicians were forced to purchase EHRs to comply with very prescriptive federal requirements, right? So to risk a pay cut if we didn't use it. And so if we have to use it and we have to buy it, what's the incentive to improve the product, right? And so there was a little bit of a poor calculation and a poor rollout of this. And so the result of this mismatch between the federal regulation and what physicians really needed to care for patients was creating a situation where physicians were less efficient. A few years ago, the joint study was done by the American Medical Association and the Mayo Clinic that found that the average physician spent 2 hours on paperwork and data entry for every hour spent treating patients. Right? I mean, that's crazy. It's not at all the best use of an education that nowadays, when you finish med school, oftentimes you have $250,000 in loans, right? So $250,000 education to spend a 2-to-1 ratio doing paperwork versus patient care, right? I mean, now my wife and I, when we retire, I go up to sleep and she's on her laptop with the glow of the laptop keeping me from sleeping because she's catching up on her notes for the day, right? So, all the hours she spends in the office, and then add to that the hours of sort of chronicling all that information in this computer. So in fact, that burden created by electronic health records and other documentation is the leading cause of burnout among physicians. Physicians relative to other white collar workers have more than twice the burnout rate relative to those other white collar workers. And so this is the most contributing factor. So the AMA is working to reduce this burden by partnering with technology companies to make these EHRs more efficient and interoperable. It's just almost insane that my wife, for example, does robotic gynecologic surgery, right? So cutting edge stuff, right? Using this Da Vinci robot, it's called, and she's at the robot, and the robot is doing the controls, and the robot's doing the hysterectomy. And then she comes to the office and she literally has to fax the operative note from that cutting edge procedure that she just did to the primary care physician, because those EHRs, hers and the primary care physician's electronic health record, are not interoperable, right? So robotic surgery at 9 a.m. and then fax machine at noon to fax over what she did. I use the metaphor that it's like George Jetson and Fred Flintstone living at the same time. I mean, that's literally what it is, right? Robotic surgery and fax machines. I ask other people outside of medicine how often they use their fax machine, and they laugh. I did it this past weekend. There's a conference that I went to of non-physicians, and they all sort of chuckle. They said, we don't even have one, right? And yet it is used 50 times a day in my office, right? And that's a problem, right? We have electronic health records and we're still faxing records because of a lack of interoperability. So we've worked successfully with federal regulators to make it clear that more of the care team can and should document information in EHR, so the burden doesn't rest solely on physicians, right? It should be everyone involved in that patient care that's putting in that information, not just the typist with the $250,000 in medical school loans. So, as far as pitfalls in healthcare technology, so the lesson of the EHR, the cautionary tale is that physicians and other healthcare professionals must be involved in the planning and design and implementation phases of this new health technology. Just as we witnessed with EHRs, the rest of digital health is at risk of underperforming if physicians aren't involved in that innovation cycle. And in fact, you'll hear similar stories about other types of health technology, including faulty apps, right? In 2016, there was a smartphone app called Instant Blood Pressure, and it was downloaded more than 100,000 times. The problem is that it was wrong about these blood pressures 8 out of 10 times, right? In a 2019 study, it found an algorithm used by United Healthcare was biased against Black people because it used health costs as a proxy for health needs. So the algorithm falsely concluded that Black patients were healthier than their white counterparts, when the reasons for their lower healthcare costs are far more complex, like less access to care, more mistrust in the system. Another example I'll give you is that, using artificial intelligence or augmented intelligence, there was a protocol that said that they looked at diabetic patients in the hospital and which ones could go home early versus which ones needed more intensive treatment. And what was odd was that everybody knew that what we call brittle diabetics whose sugar is very fragile, whose health is very fragile, those are the people that needed the most attention. This AI algorithm said that those were the very people that could go home sooner than those people who had better controlled diabetes. And the reason for that is that when you look at the attention that the brittle diabetic gets in the hospital, they were getting their vital signs checked every hour. Their insulin was dosed regularly. Their vital, their blood sugars were checked more often. So they had more attention on them, which is why the output, the metrics about control of their sugar looked good. It looked better than those people who weren't getting that attention. So because the brittle diabetic population was getting more attention, their output looked better. The computer said, oh yeah, these are the ones that can go home sooner, right? Completely wrong. And so we have to be careful about how we program and how we rely on this. So it's a demonstration of the pitfalls of technology there. So, New York investigating this, United Healthcare's use of this algorithm, steering Black patients away from getting higher quality care because, again, the algorithm was wrong. So COVID-19 and the explosion of telehealth, there's a question in the chat. Do I favor the use of a scribe, which would allow physicians to maintain eye contact? Yeah, I mean, I don't use one because it costs money and it's another person in the room. My wife would probably be uncomfortable with that, being a gynecologist, having somebody in the room that the patient doesn't know who they are, that sort of thing. So there was, again, the question is about a scribe. I would say that's a Band-Aid for the underlying problem. What's not a Band-Aid is robust voice recognition with robust augmented intelligence that captures the conversation and then puts it in the form of a note where all I have to do is talk like I've always done, right? Even before electronic health records, and then it captures the conversation. That's a good solution. A scribe is a Band-Aid solution for that, I think. But as you might imagine, again, the AMA has spent much of the past 2 years on the COVID-19 pandemic, working very hard to provide physicians with resources and information to advocate on behalf of physicians for funding and regulatory changes that are needed as a result of this once in a century, hopefully, global health crisis. So the AMA's response to COVID, we responded to the public health crisis in 4 very important ways by providing, one, a trusted, evidence-based resource and clear guidance to physicians on the front lines, resources that can be accessed for free on the AMA's website, right? So in this rapidly evolving pool of information about this virus and vaccinations and efficacy and how to prevent it and masking and hand washing and sterilizing things. I mean, every month there was every week there was new information coming out. So providing sort of evidence-based resources to physicians was critical to our role here. Helping physicians and practices recover from the disruption and damage of the pandemic by pushing for loans to keep our practices open, other sorts of financial assistance, and providing guidelines as far as how to safely reopen. Pushing at the highest levels of government to deliver necessary equipment such as PPE to reduce the obstacles to patient health. My son, that's a bioengineer, when he was home because of COVID, we had purchased 20 3D printers to donate to Flint community schools, just because I think it's a skill that's up and coming, that if school kids learn that at an early age, they'll have a leg up when they enter the marketplace. Well, school's closed. And so here I was with 20 3D printers in my dining room in boxes that we unboxed and started to print N95 equivalent masks, just because you couldn't find them back then, right? So my son and I are 24/7 for several months. We're printing N95 equivalent masks to sort of supply to our healthcare workers. People would come at all hours, and we give them a Ziploc bag with the N95 mask, the filter material, the elastic band, so they could size it. So, again, just a small example of where we were with PPE. Now, everybody has the mask that they need now. But at the beginning, that wasn't the case. And so our goal as an organization was to get that necessary equipment into the hands of people. And also advocating for science-based equitable policies on pandemic control strategies, testing and vaccine development and distribution. When you look at Genesee County, which is where I live, if you look at the vaccination rates, even today, but especially, even a year ago, the southern part of the county, the more affluent part of the county, had a 70-some% vaccination rate. The city of Flint sat at 30-some%. It might not even be above 40% even today. The access to the vaccine, awareness and knowledge about educational content about the role of the vaccine is something that was lacking. So there's a differential in health outcomes related to COVID based on vaccination, obviously, and there's a differential in vaccination rate based on zip code. And so when you go down the road and sometimes you see these billboards that show, 48503 is a city of Flint zip code. 48439 is a Grand Blanc, Michigan zip code, just one zip code down where my parents live. The life expectancy in 48503 is something like 68 years. 48439, which is where my parents are, is like 80 some years, right? And this is modern day America. So this is a lack of equity. And so it's an important thing that we're focused on to sort of improve equitable policies. So a voice for science. One of the most disturbing aspects is, again, this misinformation and disinformation and politicization of a scientific issue, a medical crisis. So this disinformation online and politicization of these health issues have eroded the public confidence in science and undermining sort of trust in physicians and medical institutions. And so though these trends have existed for decades, they've been particularly acute during the COVID-19 pandemic. So unfortunately, as the pandemic has unfolded, we've seen scientific advisors and sound medical advice and even physicians themselves demonized for political purposes. When I advocated that that the school system should maintain masks when COVID was still rampant in this area, there's a group called Unmasked Genesee County Kids that came to testify at the same county commissioner's hearing. And after I gave my testimony, a guy came down and sat next to me, and he was on the other side of this issue. And he was very riled up because he had got a standing ovation from this unmasked Genesee County crowd, and basically told me that he was going to be waiting for me outside to F me up. And I had to get a police escort to leave there. And then I started to get hate mail that basically said everything from, go back to your own country, your dictatorship. Of course, I was born in Pittsburgh and I had nowhere else to go, but all sorts of threats that came from that. So this is kind of what happened with science that's been demonized for sort of political purposes. So we physicians found ourselves fighting a war on two fronts, caring for the severely ill patients in a raging pandemic, while at the same time battling a public relations war that questioned the legitimacy of our work and our motives, right? I mean, threats like that. So the AMA continues to call on all elected officials to affirm science and evidence and the facts in their words and actions. And the media, we're asking to be vigilant in communicating factual information from credible sources. And yes, there's debate to be had, right? This is not something that's a final science. I already mentioned how often our recommendations had changed based on what we were learning. So acknowledgement of that, but sticking to what's been proven during the pandemic itself. Social media platforms to advance evidence-based information from credible resources and sources, our healthcare institutions to base decisions on scientific evidence and data, and our government scientific institutions now and in the future to be led by experts, and for the actions of our government leaders to be guided by those experts and based on best available evidence. So to the extent possible, we've sought to be a trusted voice of information in ourselves through the technology and through all the, you see the screenshots here of the media work that we've done.
Dr. Mukkamala, we have a question from an attendee here joining us. I'll invite Ralph Fairbanks to unmute himself and pose his question to you directly.
Sounds good.
Yes, thanks, Doctor. I'm going back to what you said about the fax machine and technology like that. I'm fortunate enough to have insurance both through Priority Health and the Veterans Administration. Is the coordination across those two platforms done via a fax machine, or is there some other way that, when I go to see one doctor, he takes the results and it gets to my other doctor?
Yeah, so if both doctors happen to use the same system, right? So within the VA, the VA is actually very cutting edge when it comes to interoperability within the VA, right? But as you know, there's sometimes the wait to get into the VA for something is long. So I see patients in my office that the VA sends me. When the VA sends me the record of the hearing test for that patient, for example, they're faxing that over to me, right? Because I'm not on that VA system. And what I'm on and what they're on is not interoperable. So absolutely, that coordination of care, or the lack of coordination of that care, yes, those records are being faxed. Now, again, within the VA, they're not, but from the VA to the outside world, they are, right? And I've got an interesting story real quick about the VA and its technology. So when I was a medical student at the University of Michigan, the Ann Arbor VA had a DOS-based system, but it was cutting edge. The University of Michigan hospital, the university hospital, was on paper. And yet here we were at the VA just across the street or down the street that had a computerized system. And there was a patient there. I remember his name, and his family has given me permission to share his story. Ralph Steinhauser was probably in his 80s. And he was there at the VA. And he was there for a reason. They couldn't figure out what was wrong with him. He was running fevers every night to 104 degrees, like ridiculously high fevers, weight loss, all sorts of things. And they were trying to figure out what was wrong with him. And so as a third-year medical student, I logged into the system because I was on call one night and I was bored, and I was just doing some documenting of whatever my tasks were as a medical student. And I pulled up Mr. Steinhauser's medical record from an admission 10 years prior, right? So this was 1994. In 1984, there was a record of his admission into the VA on a DOS-based computer system. And during that admission, they discovered that Mr. Steinhauser had lymphoma. Well, lymphoma is the main cause of nighttime high spiking fevers. And he had recurrent lymphoma, which is what would put him in the hospital there. So because I looked into the system in the 90s in the VA, I discovered that Mr. Steinhauser was there because he had recurring lymphoma. They hadn't figured that out yet. Right. And so it shows you the robustness of the VA system. It's a little bit of a tangential story, but it sort of illustrates where the VA is and was as it relates to technology. But again, if Mr. Steinhauser got admitted to the university hospital, they're faxing that record over. Yep.
Thank you, Doctor. And thank you, Ralph, for the question.
Yep. So, increasing, so the popularity of telehealth, it's been very difficult 2 years for healthcare workers, but there's some bright spots. And one of the brightest is we've discovered that telehealth is really popular, right? And so it's an effective way to provide healthcare in many circumstances. It's not appropriate, for setting a broken bone, obviously, but it certainly is great for follow-ups after surgery, minor illnesses, chronic disease management. In the early stages of COVID in 2020, when stay-at-home orders kept many of us from visiting physicians for routine medical care, the use of telehealth skyrocketed. So the Mayo Clinic reported that their system saw a nearly 11,000% increase in virtual visits in the first few months of this pandemic. That was the only way to get care. So another study showed that more than 90% of physicians, including caregivers on the very front lines, were treating patients remotely. And nearly half of those physicians were using telehealth for the first time ever. And so, some practices are ripe for telehealth. My wife is an OBGYN, as I mentioned. She has a lot of women exams in the elderly postmenopausal women that just need, to go over their screening mammogram results and just go over their medication management. And that's very amenable to telehealth. So Nita's been doing that, and the patients love it. The fact that they don't have to come in and sit in a waiting room with a snot-nosed kid whose tonsils I'm about to take out is sneezing on them in the era of COVID. They love being on the screen like this. But it's hard to examine the ear of that snot-nosed kid for me because technology isn't available for that, right? So there's a varying sort of role for telehealth. So in telemedicine, like across digital health, physicians have important insights into how to maximize its reach and effectiveness. So the AMA is working on this issue in two ways: getting physicians familiar and comfortable with that technology, and also helping them to integrate it into their practices. So we're also working at the federal level through our advocacy efforts to remove barriers to telehealth implementation and to ensure sort of greater access to these services. So, for example, one of the most significant barriers to wider adoption of telehealth has been restrictions on where patients can be located to receive these services under Medicare rules. Medicare used to only pay for this if you're in a rural area, right? That doesn't help my wife's patients in Flint, Michigan that love their telehealth, but Medicare doesn't pay for it because they live in Flint and not, in the Upper Peninsula. So at the AMA's urging, CMS temporarily removed these restrictions at the beginning of the pandemic, which means that Medicare now, those patients can receive telehealth services from the comfort and privacy of their own homes, whether they're in the middle of the UP or in Flint or Detroit, no matter where those homes are located. So now we're working to try to make these changes permanent, and we're supporting several bills in Congress that would remove these sort of goofy geographic restrictions on telehealth. So earlier I mentioned that one of the AMA's strategic priorities is to lead the charge against health crises. And so, chronic disease. So the prevalence of chronic disease and its impact on people is a growing health crisis, and a very expensive one at that. So the staggering number of Americans that are dealing with chronic disease, such as diabetes and hypertension, nearly 90% of all healthcare spending in the US involves people battling one or more chronic conditions, according to the CDC itself. So roughly 1 in 3 Americans have prediabetes, 90% of whom are undiagnosed. They have no idea. And more than 100 million adults in the US have high blood pressure. About half of them are uncontrolled. I went to a local high school, my alma mater high school, Powers Catholic High School here in Flint, has a group of healthcare students. And so I took them with me to the local farmers market, and we set up a table, and we had these blood pressure cuffs, and we were measuring people's blood pressure, anybody that wanted it. And we discovered, just out of the 50 or so people that we checked their blood pressure, probably 20 of them had no idea that their blood pressure was elevated until that moment. Right? These are 20 people that had they not been told that, and maybe they'll do something about it, maybe they won't, but at least now they know that it's something to mention to their regular doctor. Had they not done that, this would have been a heart attack in the making 10 years from now, or a stroke in the making 20 years from now. And so, reducing the rate of chronic disease is a strategic priority of our AMAs. And so, technology can help tremendously in fighting chronic disease. Patients are more informed than ever before due to access to information. Patient portals. Pre-pandemic, approximately 60% of patients had access to their health records and a physician via a patient portal. Mobile phones, wearables, tablets offer access to chronic disease monitoring apps, health style apps, that measure steps, measure calories, measure sugar, fitness, mental health apps, things that remind us to stand up and stretch. I'll be in the middle of a meeting, in the middle of a speech sometimes, and my thing says it's time to stand up and stretch. And then I sort of whack it and tell it to mind its own business. But it is useful information, right? To remind us to do that. Online prevention programs. So there's a group called Amada Health that offers online prevention programs that focus on mindset and behavioral changes to prevent and manage chronic conditions. So it's been a very useful use of technology. Physicians know, that the best and most cost-effective way to ensure good health is to address diseases at early stages, right? There's an investment that can happen early that prevents an expense down the road. And that includes early diagnosis and treatment of chronic diseases that can lead to debilitating issues later in life. So the Black and Latinx communities suffer disproportionately high levels of chronic disease, especially heart disease. So consider that, for example, Black adults are 40% more likely than whites to have high blood pressure, and they're less likely to have their blood pressure under control. And cardiovascular disease kills nearly 50,000 Black women alone annually, and half of Black women 20 and older have heart disease, but only 1 in 5 believes they're at risk. So there's major disconnect between, 50% of people have an issue, but only 20% realize they have the issue, right? So a big gap there that needs to be filled. In 2020, the AMA launched a public awareness campaign called Release the Pressure. It's a partnership with Essence, which is a magazine that's very popular in the Black community, that provides Black women with resources to identify and track their blood pressure numbers, as well as develop a wellness plan with existing personal support systems of family and friends to collectively sort of manage their heart health virtually. And so this website gives women everything they need to get started, from information about how to measure their own blood pressure accurately at home, when to notify their healthcare provider, their physician, as well as tips on diet, physical activity, reducing stress. So tens of thousands of women so far have taken the pledge to protect their heart health. So it's an investment via technology that's going to pay off in preventing heart attacks and strokes downstream. So the effort, it builds on the AMA's previous work to reduce hypertension, including our longstanding partnership with the American Heart Association in a thing called Target BP. This was kind of part of what we did at the farmers market, just making people aware of their blood pressure issues, to reduce the number of Americans who have heart attacks and strokes by urging physician practices and health systems and patients to prioritize blood pressure control. It's the silent killer for a reason, right? I mean, I could have a blood pressure right now of 180 over 100 and have no idea until I put that thing on my arm and it tells me so. And that's that aha moment. So more than 2,600 healthcare organizations have joined this movement to make heart health a priority, sharing this common goal to improve health outcomes associated with heart disease. So, we're partnering, working with the CDC, the American Diabetes Association, the Ad Council, to expand awareness of prediabetes by asking Americans to visit, doihaveprediabetes.org. It's a simple 7-question assessment to determine somebody's risk of prediabetes. Again, how would you know unless somebody asked you those questions? It's not something that occur to us. We're feeling great, and when we don't feel great is when we go in. Well, we can have prediabetes and feel great and do something about it, so we never get to that point of not feeling great. Additionally, the innovation company that the AMA founded in Silicon Valley, it's called Health 2047. 2047 is the 200-year anniversary of the founding of the American Medical Association. So this tech company, the innovation sort of incubator in Silicon Valley is called Health 2047. It launched a company that aspires to provide community-based peer-to-peer coaching to help people with prediabetes, to make lifestyle choices that can keep their condition from advancing, right? So the interaction with the healthcare system isn't just when they leave the home and go to the hospital or go to their doctor's office. It's in their own room, on their computer screen, just like we're looking at right now, where you might log on and your peer-to-peer coach or your physician can say, hey, what are your sugars doing nowadays? What's your weight? What's your blood pressure? So it brings the care into where they are, as opposed to having them have to go to that care, which is horribly inconvenient for many people. So this company, First Mile Care, leverages the power and convenience of today's on-demand economy to improve the lives of people with chronic conditions. So First Mile Care brings this Uber model, so to speak, to diabetes prevention, giving people 24/7 online access to peer coaches in their community to give them the support they need to live healthier, better lives. And the goal is to cut in half the number of people in the US with prediabetes by 2028. So a lofty goal, but something that, again, it's not expensive. It's an awareness and planting the seed in the mind of people that, hey, this is something you should look into. And we also continue to advocate for more payers to cover patient participation in these national diabetes prevention programs, right? It's, again, investing something today to reap a dividend later, a dividend that means a life saved and also dollars saved down the road. It is so much cheaper to pay for a coach to deal with somebody with their prediabetes and help them now than having them have an amputation due to uncontrolled diabetes 20 years from now, right? It's just, the math is just so crystal clear and simple. So, again, advancing health equity and innovation and across healthcare is a very important strategic priority for the AMA. It's often said that technology will be the great equalizer in medicine, improving access to care of marginalized and rural communities by breaking down the traditional walls of the exam room. Don't make people come to my exam room, instead meet them where they are. So breaking down that, the figurative wall of the examination room. By advancing health equity through technology, it's not going to happen by accident, right? So if we're serious about eliminating the inequities in healthcare that contribute to these poor outcomes, then we must be intentional about creating that. So we've got to be strategic in our plan. You can't wait for it to sort of evolve organically. We have to be strategic in our planning and purposeful in our execution to make that happen. And so it's just too important to leave to chance. So as far as our commitment to non-discrimination, there's many racist systems and discriminatory structures that perpetuate health inequities in historically marginalized communities. So not only is this unjust, it's avoidable. And that's why the AMA has placed equity at the center of our work to improve patient outcomes. And so our work to create a more equitable healthcare system is guided by our code of medical ethics. We were to provide competent medical care with compassion, but also recognize our responsibility to seek change when it's contrary to the best interest of our patients. And so this non-discrimination, health equity, and access to health are all key goals for our advocacy work when we're in state capitals and in DC. So we recognize that, that racism is a major public health threat, we urge sort of a multifaceted approach to these social determinants of health. And I'll just give you the example of the Flint water crisis, right? So Nita and I, we live in the city of Flint. We had lead contaminated water. Immediately, as soon as we heard that, I called a company, and now we're on well water. We are off the grid, right? But we have that luxury. That $5,000 bill is something that, you know, less than 1% of the people in the city of Flint can afford. And so this is a social determinant of health. My wealth and social status gives me the ability to avoid the risk of drinking lead tainted water that other people couldn't avoid, right? And had everything from skin issues to behavioral issues in their children. So this is an example of a consequence of social determinants of health. Recognizing, for example, the structural racism that exists within some examples of police brutality that we've seen, and that race is a social construct, not a biologic construct. You know, the fact that when I was at the University of Michigan, we were taught that the glomerular filtration rate, right? So kidney function in a Black person could be this number, and in a white person would be this number, right? There's no difference between a Black person's kidney and a white person's kidney. There's no reason those numbers should be different. But here I was being taught that it's normal to have this number if you're Black and this number if you're white. That's not a biologic phenomenon, right? So this is what we're learning about, you know, race is a social construct, not a biologic construct. So in 2019, we created the Center for Health Equity that serves as a hub for this equity work. And so our goal is to promote equity in care, advocate for healthcare access, you know, research, increasing the healthcare workforce diversity, cultural awareness, you know, social determinants of health, and to, you know, give a voice and commitment to improving health equity. And so what we've done so far, you know, again, raising awareness of the impact of, for example, of police brutality, something that we see in the news from time to time, urging tracking of COVID-19. When we first started tracking COVID-19, again, you know, when my son and I were making masks here, and I was, you know, I probably tested 5,000 people for COVID, because at the beginning, when we were talking about putting a swab this long in somebody's nose and people were talking about how miserable that experience was, who better to do that than the guy that works in people's noses all day? So I volunteered with my health department. I said, hey, I got this. And so I was swabbing thousands of people, but going from then, you know, to, you know, tracking COVID-19, when we were doing that and diagnosing COVID, we weren't tracking, you know, where it was happening. We weren't doing it by race. We weren't doing it by ethnicity. Then we had an aha moment that said, you know, there's a differential impact of this pandemic based on race and ethnicity. We should know that, right? We need data to get that. So now when you get your COVID test, you know, they'll try to record that data so we can see where is it peaking and where is it okay. I'll go on here. So as far as our strategic plan regarding health equity, you know, our plan for racial justice and health equity is driven by the need for equity-centered solutions to confront the harms that are produced by systemic racism and other forms of oppression. So we have an ambitious 3-year strategic plan that seeks to embed equity within the American Medical Association, build alliances with marginalized physicians and other stakeholders, and to push upstream, right? To go to, you know, the fact that, you know, when I went to a grocery store on the north side of Flint, different than when I usually shop, just to kind of see what that's like, and was just amazed to see how much preserved, boxed, canned stuff and lack of fresh food there was in this grocery store, right? High salt content, you know, high preservative content. That is an upstream cause of downstream hypertension, for example, right? So we need to go upstream to look at that social determinant of this high blood pressure, and ensuring equitable structures and opportunities for innovation, right? And fostering pathways for truth and racial healing and reconciliation of our past with the present. So, and also equity within innovation, right? So our strategy calls for embedding racial justice and health equity within our innovation efforts, equipping healthcare, the innovation sector, to advance equity and justice, centering and amplifying historically marginalized healthcare investors and innovators. So looking at those ideas that will actually solve some of these problems. And, you know, a new policy that we adopted, that House of Delegates, that congressional sort of body of medicine that I mentioned in June of 2021, called for fair and equitable payments, whether the service was provided audio only or audio visual or in person, you know, because again, telehealth has been wonderful during this pandemic, but it would not be nearly as embraced if it didn't compensate the people that were doing it, right? So the fact that now it's equitable sort of payment for this service has really made it the uptake and the delivery of that service much more widespread. So the policy includes several provisions for making it more accessible, recognizing that access, for example, to broadband internet is a social determinant of health. If we move to a point where my wife is doing well women exams via telehealth, and yet somebody doesn't have broadband internet so that their webcam and their audio come through clearly, they don't have access to this evolving, improving method of delivering care. So something as simple as broadband internet access is a connection between technology and healthcare outcomes. And so numerous initiatives to improve access to telehealth for historically marginalized and minoritized communities, expanding physician practice eligibility for programs to purchase these services and equipment for telehealth services. So earlier I mentioned that one of our strategic priorities is driving the future of medicine through innovation. Looks like there's a question here. Does the AMA have a project to increase participation of disadvantaged populations in clinical trials? Absolutely. And so clinical trials traditionally have been at university centers, right? So University of X or X university is where these things have traditionally happened. But we're very much in favor of expanding that so that physicians' offices, like if Nita and I wanted to do a clinical trial, that yes, we are working towards making that happen and equipping us to be able to do that. And that's how you're going to get, because there's no university in downtown Flint. There's no university on the north side of Flint. If those patients want to be in a clinical trial, they're traveling an hour to go to a university. Now they have to travel 15 minutes to get to our office to participate in those clinical trials. So yes, we're definitely moving in that direction. Let's see, where am I? So if you look carefully at the current and future trends in medicine, there's some challenges and opportunities. The trends include increasing digitization across healthcare and business, continued rise in chronic disease, right? Hypertension and prediabetes aren't going anywhere until we solve that problem. Major public health events, the next COVID, aging populations, right? So the prevalence of disease associated with aging naturally goes up when the population average age gets older. Increasingly diverse patient communities, the growth in remote care, right? So these are all opportunities and challenges. The rise of augmented intelligence is another thing that I mentioned earlier. So as far as digital technologies from wearables, to augmented intelligence, they offer almost limitless potential to transform healthcare, not only in how we physicians practice, but how patients experience it. So as I mentioned earlier, without direct input and guidance from physicians in the early stages of this conception and design, far too many of these technologies will fail to deliver, or worse still, they'll complicate healthcare for patients and physicians, right? Creating technology that isn't helpful ends up just being a barrier, right? When somebody comes in with reams of data from an inaccurate blood pressure measurement thing, that now is somebody has to go through that data and figure out, okay, does this patient need a medicine? Or is it the thing that they're wearing on their arm that's miscalculating this, that's creating this appearance of hypertension, and it's not actually as bad as we think, or it's worse than we think, right? It could be anywhere. And so it's so important to have quality information. And so, we should be working, towards the quadruple aim of improved patient care, happier clinicians, lower healthcare costs, and better outcomes, right? So, you can have improved patient care by having technology come in and it captures data the way we want it. Clinician well-being when it comes in a way that I can use it, as opposed to reams of data that I have to be looking through at midnight before I go to bed. Lower healthcare costs because now we're preventing that pre-diabetic from turning into a diabetic, and better outcomes for patients because now that pre-diabetic never gets to be a diabetic and never ends up having a heart attack, right? So this is that quadruple aim, so to speak. So if new healthcare technologies aren't designed to accomplish at least one of these goals, and hopefully more than one, then what's the role of that technology? So we have to make sure that we measure any technology against these 4 outputs to see if it's going to get us there or not. So making healthcare technology an asset. So in short, the AMA is focused on making technology an asset, not a burden to deliver on the quality of care, the improvement of quality. That's why we built a powerful network to help drive the development of new technologies, flipping the traditional model of innovation by leveraging physician experience and expertise into the early stages of design. there's a conference called the HIMSS conference. It's a massive technology conference. I think like 40,000 people. And I went on behalf of the American Medical Association to Orlando pre-COVID. And it's just acres of all sorts of technology, everything you could imagine. And I was just shocked at the paucity of physicians in that room. Because at the end of the day, this is technology that we're going to be asked to use to help our patients. And yet it was like a 99% non-physician crowd that was talking about this does this and this does this, and this is why we did this. Where are the physicians in that room in the development of that technology and the evaluation of that technology, right? When we are absent, technology doesn't help our patients. So, connecting physicians with those innovators. So because of this reason, we created the AMA, the Physician Innovation Network, another platform that connects the world of medicine and innovation by integrating that clinical voice into those technology solutions. So in 2017, this network has more than 15,000 users and 30 collaborators from across the industry, right? So that the left and right hands that both want to improve patient care actually know what each other is up to and are working together to accomplish that. So, Medicine's Next Frontier, I mentioned Health 2047, which was founded in 2016. It's again, a Silicon Valley for-profit enterprise that's building and commercializing solutions for healthcare challenges. So we're bringing together a network of innovators and corporate partners and AMA members to make data liquid, right? So enable data liquidity, realign the healthcare system to better manage chronic care, not just waiting for the hypertensive patient to have a heart attack and a stroke and then taking care of it, but instead to prevent that stroke from happening, to manage that chronic care so it doesn't become acute care, to enhance the productivity at all levels of care and support, and to improve value-based payments. And so I mentioned First Mile Care, which is again building this affordable, scalable platform to improve the lives of people with prediabetes, getting them some peer-to-peer work at home on their computer screen so they don't end up in diabetic ketoacidosis 10 years from now. And this is all available at health2047.com is the website for that if you want to see that. And these are all the different products that we're sort of rolling out, where technology is developed by physicians because we know what it's going to take technologically to help our patients, right? So not in the absence of physician input, but with physician input. So augmented intelligence, I mentioned, is defined as the ability of a computer to complete tasks in a manner typically associated with a rational human being, to function appropriately and with foresight in that environment. So machine learning is part of the discipline of AI, and it refers to constructing algorithms that can make accurate predictions about future outcomes. Sometimes they're wrong, right? The prediction that the brittle diabetic is the one that can leave the hospital fastest, right? But it's only as good as what we put into it. So at the AMA, we use augmented intelligence because we emphasize the fact that this technology is to be designed to enhance human intelligence, not replace human intelligence. So as a discipline, AI has been around for 70 years, right? And so the underlying techniques, the methods, they're not new, but what's new is the inexpensive and ultra fast computing power that allows us to supercharge these sort of the core of AI to create applications that have the potential to transform healthcare, right? So it's that computing power that's really sort of spearheaded the faster evolution of AI. So some examples, this cardiogram app, for example, it works with a heart rate sensor of the Apple Watch to detect hypertension and sleep apnea. And so in a study involving more than 6,000 patients at UCSF, the app and its machine learning deep heart detected hypertension and sleep apnea with an 82% and a 90% accuracy, right? That's pretty darn good for somebody that had no idea whether they had sleep apnea or hypertension, that puts on a watch and an app. And now with a 90% accuracy, they're like, wow, this thing's telling me I have sleep apnea. Maybe I'll go in and get a sleep study, right? And before, that would have waited who knows how long to get diagnosed. The Human Diagnosis Project is an online platform that uses machine learning algorithms to help physicians achieve accurate diagnosis and receive specialist consults for their patients, right? So again, bringing care to the patient instead of, if somebody sees their primary care physician that needs to see me for their hearing loss, that's 2 visits, 5 weeks apart, and there's just a more efficient way to do it. Surgical robotics, right? Like I mentioned what my wife does with the gynecologic robotic surgery. Advances in this field allow surgeons to use robots to perform surgery with very fine detail and fewer tremors than the human hand, right? So AI might one day allow for these robots to perform surgical procedures autonomously, and we're not anywhere near that yet. But the better we make that technology, the more likely that is to happen, right? And the military has applications for this, where the surgeon, isn't going to be on the battlefield or at the surgical hospital on the front line. They're somewhere else, but they're able to do an aortic repair remotely because of this technology. So opportunities for physicians and patients, AI, again, lots of opportunities for office and hospital automation, for data mining, right? Trying to find trends early on before it occurs to the human brain, that maybe there's a link here. It can occur to the computer much sooner. Diagnosis, analyzing all the known data about patients and insights about diagnosis and treatment related outcomes, which treatment is working better than others. The computer can sort of detect those things before it even occurs to the human brain. And so again, just lots of opportunities for physicians and patients to be involved in AI and its deployment. And as far as challenges for physicians and patients, the data structure, the data integrity, data security, these are all things that we hear about. Technological mistrust, right? So the fact that, when something comes out that fails me 2 or 3 times in a row, what is my likelihood of adopting the 4th thing that comes out? Very low, right? So there's a mistrust that happens, and that's why transparency and acknowledgement of the benefits. It shouldn't just be a sales pitch when it comes to technology, right? It should come with an acknowledgement of what the potential limitations are. And susceptibility of training bias, right? So what is the bias of the person that's training me for or against something? That's all something that we need to consider when we look at new technology. Ethical considerations, so for example, advances in AI and machine learning offer the potential to provide personalized care by taking into account patient differences. However, the same ability to discern between patients brings with it the risk of amplifying a bias, right? So we can take something that we are biased about and amplify that based on what AI tells us, right? So we look at what we get and it seeks to sort of reinforce our bias. And we need to just be aware of that. We need to be careful about that. We're getting close to the end here. Innovators, entrepreneurs, they're all working to determine the appropriate clinical applications of AI. And to advance that work, we have, policies on AI. So the American Medical Association has came up with these policies to guide it so it becomes what we want instead of what we don't want. And it's based on the principle that AI should advance the quadruple aim, right? So we're looking for oversight and regulation of care. So we're not bombarded with a bunch of products with no regulation about it, where now people are scrambling to figure out, is this really telling me what I think it's telling me, or is this something wrong, right? Payment and coverage for healthcare AI, right? So nothing goes very far when it doesn't get paid for. So my ability to look at even high quality data about a diabetic and their sugars, if I'm not getting paid for the time spent looking at a list of 1 month's worth of blood sugars, then it's not really going to be very useful to the patient. And so, payment and coverage it should be informed by what it takes to actually look at that data. So, as we've seen, I know I went very fast and I apologize for that, but I'm looking forward to your questions. The use of various forms of technologies in healthcare, from wearables to online monitoring to AI, offers both, promises and potential pitfalls. And so the key to successful adoption is physicians' involvement in all stages of development, right? We don't want something that we weren't involved in, that when it does come out, we say, hey, did you think about this? Did you think about that? No. Well, then I'm sorry, we can't use it, right? After it's already been developed, where we could have been there years earlier and make it what we actually find useful in our practices. So we've covered a lot of ground. Thank you very much for listening, and happy to have that conversation with questions now.
Okay, any questions for Dr. Mukkamala?
I have one. I actually have a layered question.
Sure.
This presentation, first of all, appears to be a page right out of the AMA strategic plan or close to it. Am I correct there?
Yeah, I mean, so certainly this is a component of our strategic plan, right? Technology, right. There's much more to our strategic plan than just technology, but yes, it's an integral part of it.
Okay, my question, 2 questions. What percentage of licensed physicians are members of the AMA? And part 2, assuming that number is too low, what is the plan for the AMA to pry physicians out of their specialty silos and view the broader world of medicine to make these things in the strategic plan happen? Thank you.
Two critical questions. So as far as percentage of physicians that are members of the AMA, if you look at the million physicians in the country and the 200 some thousand, you get to about a 20% number. That includes physicians in training, right? So it's actually less than that. So the minority of physicians are members of the American Medical Association. Now, to your next point about how do we get them out of the silos to sort of acknowledge the work that's being done and being involved in this work by either by joining and participating in it, that's, I guess what I would say is, even though those physicians aren't members of the American Medical Association, by nature of the fact that the state that they practice in, so the Michigan State Medical Society sends 15 people a year to the AMA to make policy, right? The Louisiana State Medical Society, the Alaska State Medical Society, and their specialty societies, right? So the American Academy of Pediatrics, the American Pathology Association, the American College of Surgeons, right? If they're a pathologist, a pediatrician, or a surgeon, they're still represented. So even though they may not write a check for dues to the organization, by nature of their professional memberships, that group is also making policy within the AMA. But how do we convince the individual? That's why we have an entire membership and member experience sort of group within the AMA, just to let them know what we are doing. But oftentimes what I see, and just to be perfectly frank, one thing that we do that they don't like is enough to trump 10 things that we do that benefit them, right? And they use it as a litmus test, and they say, you know what, you came out and supported the Affordable Care Act. I'm not a fan of that. And they ignore everything else that we've done on behalf of physicians and our patients because of that one decision more than a decade ago, right? And so this is where our MMX team serves to sort of fill in that gap of knowledge.
Presumably, there's a way for you to influence medical students, have access to them, and residents at various teaching institutions.
Yeah, absolutely. And so we have a very large membership, but there is a trailing off in that gap, right? So between medical school and residency, then they join the workforce. And in that first decade, family issues, hard work, new work environments, all of a sudden, the AMA takes a back seat. And then sometimes they find their way back. But great question.
Thank you, John. We're going to go to Richard Swanson next. Richard, go ahead and ask your question, please. Thank you.
Okay, well, basically, doctor, we talk about telehealth, and I'm a great proponent of telehealth. But much of the equipment that we need to monitor somebody at home, such as a blood pressure cuff, a pulse oximeter, isn't paid for. So as a member of one of our Rotary organizations, I got a grant to one of the big health networks nearby here in Michigan. And we provided them with money to buy these pieces of equipment, which were not covered by insurance. We also bought mobile phones for many of these people in rural areas who didn't have them. We even bought Chromebooks. So we need to realize that telehealth is great. As a rheumatologist, it doesn't help me a great deal as I can't examine a joint over the telephone. But it costs money to get these pieces of equipment, and they're not paid for by insurance or by Medicare. So we need to be looking at ways of funding this equipment.
Yep, no, 100%. I mentioned several times in my talk, knowing what the right thing to do is, but not paying for it doesn't really accomplish much of anything, right? And so we first, and data drives that decision, right? It's difficult to ask an insurance company to pay for something where the data doesn't support it. But when we have data to say that, yes, this intervention, this remote intervention actually saves money and improves care, then we have what we need.
That was an example, I think, with COVID. The hospital found that many of these patients were improving, and they could be sent home with a pulse oximeter after 3 days, which cut down the cost of hospitalization, and they could phone in their pulse oximeters data 2-3 times a day, or the home health nurse could come by and see it. but the insurance companies wouldn't buy it. So what did we do? We just bought them. And so what the Bronson Healthcare does is when that patient is done, that monitor goes to somebody else. But it basically, we need to look at ways from some of these social organizations like Rotary, Kiwanis, to support the health, the home health groups and the hospitals.
Yeah, I would say that that is the second best solution, right? The ideal solution should be the care that we're paying for with our insurance premium dollars should cover it. Until that happens, then we can rely on the nonprofits. I'm a Rotarian myself. We can rely on groups like that to fill in the gap. But ideally, the insurance companies should see the value of that investment.
They don't, though. You and I both know that.
I know. We
Even
keep
now,
working on it. When I go to testify in DC about insurance company issues or in Lansing, you can bet that this is very much part of my testimony. And sometimes it falls on deaf ears and sometimes it gets through because patient examples are so potent.
I understand too now that the allowing people, the doctors to get paid for being on telehealth is now being cut back. And I know you're working on trying to get that extended. But this is basically something we need to use, not whether we have a pandemic or not. That's just my own statement. I'm done. Thanks very much for listening to me.
Oh, absolutely. Thank you.
Thank you, Richard. We want to relay a question now from Norma. Norma asks, do you see hope for reducing that 2-to-1 ratio for patient time and time documenting care provided? Is there hope for that?
I think so, yes. I think the more we make people aware of the ludicrous nature of that ratio. And then this is where technology is useful, right? I mean, how great would it be if my wife, instead of having to keep me up at night with her night and table light on, typing into her computer, can instead have AI-driven voice recognition. So she can walk into her rooms on her side of the office and the computer captures the essence of what she's doing when she's talking to her patients about that exam. That's useful technology. And do I think that's going to happen? Yeah, I think that's going to happen in our lifetime, right? I think maybe even in the next decade. But it's going to be a collaboration so that when it does get developed, it's developed with physicians' input so that we're capturing what we want to capture and not useless data.
Dr. Mukkamala, you shared a link in the chat. Can you explain what that's for?
Oh yeah, this is just a link about the 3D printed masks that I referenced earlier that I thought people might enjoy looking at. This is I think in there is a picture of my son fitting it on a mannequin that we had with the first version of it. But yeah, just again, technology coming in handy, life-saving actually.
Tom, it looks like we have time for one more question. If anyone is interested, feel free to unmute yourself.
Yeah, I guess I have a question, Dr. Mukkamala. Can you talk about the relative safety and utility of CT scans versus MRIs?
Sure. Yep. So the main distinction there is that MRI doesn't require radiation,
right?
And CT scan does. And so if you look at, somebody, for example, that's getting cancer follow-up, where they might need a CT of the chest every 6 months for a few years to make sure something's not coming back. That's a significant amount of radiation, or somebody that's pregnant, to have that sort of exposure to radiation. So an MRI is no radiation. Of course, it's a very powerful magnet. So anyone that's had an MRI knows the questionnaire that you go through to make sure there's not metal in you. Otherwise, you're not going to get one. And so CT relative to MRI, and then there's also the expense, right? And that one it boggles my mind a little bit because MRI has been around since the 80s. And yet still significantly more expensive. And then finally, I'll mention the contrast is the amount of claustrophobia that one creates versus the other, right? Yes. So a CT of the sinus is something that my patients never complain about getting. An MRI of the head, and half of them can't do it because of the noise and the claustrophobia that it induces. So finally, MRI doesn't show bone very well. Right, it's great at showing soft tissue and liquid, but not so much bone. So if you're looking for facial fractures, for example, people sort of think, well, I want the best scan, I want the MRI. Well, no, the MRI is going to suck as far as revealing that, but a CT scan of the face with bone windows is going to be fantastic.
Unfortunately, I've had to have number of MRIs, and the anti-anxiety drugs have helped me be able to stay in there for 30 or 45 minutes, whatever it is. I know exactly what your patients are going through.
Yeah.
Yeah.
Thank you, Dr. Mukkamala. We have just a fun question for you to close. You mentioned you had an interview, a televised interview after this. Can you tell us what you're doing and what you're speaking on and where we might be able to see it?
Sure. Yep. So it's the Today Show, and honestly, I'm not sure when it's going to air, or whether or not this might even just be on the website for the Today Show versus live. I'll find out here in about half an hour which one it's going to be. But this has to do with harm reduction. So one of the roles I play at the American Medical Association, aside from being a board member, is that I chair the Pain Care and Substance Use Disorder Task Force, which is about 25 to 30 subgroups, various specialty societies, state societies that have an interest in improving our quality of pain care and decreasing the incidence of substance use disorder. And one of the concepts there is what's called harm reduction. So, for example, when somebody has an opioid dependence, they are going to use, because they have a physical dependence, right? It's not a choice. You can't just say, oh, just stop doing it. It's like quitting smoking. There's a nicotine dependence there. And so to be able to use, but use it safely, is one thing. So needle exchange, for example, is one component of harm reduction. So being able to avoid catching transmittable diseases by using a clean needle as you are taking something for your substance use disorder. And then other things like naloxone, right? So Narcan, it saves lives. So access to naloxone. So if you're going to use, make sure you have Narcan available or naloxone available, so that if you do have an overdose, especially because now so much of it is illicit medicine. I mean, not even medicine, illicit drugs. So it's not a prescription driven thing. It's an illicit drug driven thing. And you don't know the potency of half the stuff that's out there. So you could easily get something from one person and be fine, and get something the next day from somebody else and be dead. And that happens all the time. More now than ever, more than 100,000 deaths associated with opioids. So harm reduction is going to be critical if we want to decrease the epidemic of death associated with substance use disorder. So that's what I'm talking about. You don't have to watch it now because you heard it all.
Well, Dr. Mukkamala, thanks again so much for taking the time from your exceptionally busy schedule to talk with us today. The presentation was excellent, and we greatly appreciate it. And best wishes to you and your family. It's good to see you.
Good seeing you too, Tom. And thank you, everybody, for having me. I've enjoyed the conversation.